developed an interest in this problem because we seem to get sent a lot of them, and I'd like to describe some of the anatomy that we've learnt and the surgical indications we use, and some technical tips that we've discovered because we went through a point of crisis in 2006 where Stu called me, Mighty Stu Walsh called me and said, I just had to do another one of those hamstrings, and it was a revision of one that had been fixed with suture anchors, which we found hasn't really worked. And he said, I'm very annoyed about it because I really struggled. And as you can see, you don't want Stu to get annoyed about anything. So we went down to the lab and worked out some things that helped us with our surgical technique, and then I'll give you a brief outline of our surgical experience. So you'll understand it, obviously the hamstring originates from the ischial tuberosity. It's medial to the sciatic nerve, which sometimes you can forget about that when you're searching through a scar ball of nerve and previous something, and used to be the origin of the hamstring. And it's deep to the gluteus maximus, and in some Polynesian patients that can be a long way down. The ischial tuberosity is a secondary centre of ossification. It appears at puberty, and there's a period where it's at risk of being avulsed, and it fuses at skeletal maturity. And what happens is, as any growth plate that's under tension, it has squamous orientated cells until the period of time of ossification when they become engorged and become columnar again. So that's a period of susceptibility to avulsion. It's the same with the proximal tibial apophysis, where the patellar tendon inserts onto the tibia. At that zone of ossification, that time of ossification, it's susceptible to being avulsed. So they always occur at a specific age, and you can also see how the origin of the tendon forms a fan. And as I say, we had this problem where Stu Walsh was getting annoyed. So we went to the lab and we did some dissections. And what we realised was, because he found the gluteus maximus was a major problem for him on this particular day. And so what we found, the more you flex the hip, the more that gluteus maximus just magically gets out of your way. So we're simple people, and we learned that the simplest thing to do was just to make sure you flex that hip right up when the patient was prone, and it instead of being covering everything like this, if you flex the hip, you can see the nerve more clearly, and you can get to the origin of the tendon more clearly. So, and this is the sciatic nerve, and this is this hamstring origin that gets injured in a very specific way. So these avulsions are usually at the age of 14 to 16, and it's this window of susceptibility, and often treated conservatively, but they come back later on in life, and their major issues are sitting discomfort. Sometimes they'll have sciatic neuralgic symptoms, and very rarely they'll get actually restriction of hip motion because the apophysis continues to grow. So it gets larger, and because it's not constrained by anything, it gets larger than it normally should be. And so that's the problem when you put these back into place, is that the piece of bone is bigger than it ever should be. So if they come to see you with sitting discomfort, operating on them and just sticking it back in place won't cure that. So you either say you can't help those people, or you go through a rather complicated process of trying to thin that piece of bone down and then get it back to where it came from, which can be difficult. So the indications for surgery are those often who have a re-injury and develop weakness when they used to function pretty well. Sitting pain particularly is difficult to cure. You can cure sciatic neuralgic pain with careful dissection of the nerve, and you can help restriction of hip motion. But as I say, the problem is the mass of the bony fragment. So this is the positioning we have for our patients, and this makes it a whole different operation. So we make a transverse buttock crease incision, and I've used this incision now no matter how long it is and how far they've gone. So you can get them down 10 to 12 centimetres retracted, and through a transverse incision you can usually get to them. You can always tee it if you're struggling, but that's very unusual now to do. So you elevate the gluteus maximus and get a retractor over the ischium, and all of a sudden things become a lot clearer. So in this is the bony avulsion. You can see we've retrieved the bony piece and placed it back with screws. But as I say, they get this problem where the massive bone is always larger than it should have been, and so they continue often to have sitting discomfort. So if they're a skinny-ass cyclist, then you're really not going to help their problem. And that's a group that is difficult to manage from that point of view. Tendon origin avulsions can be partial, where the length of the muscle is maintained, or they can be complete, where there is retraction and loss of functional strength. So this is an MRI of a partial injury, where you can see there's been obviously a lot of proximal injury, but the tendon itself remains closely opposed to where it came from, and there is really no indication for surgery. You need to reassure the patient. You need to get them on crutches so they stop doing things, and these will heal and universally, in our experience, have done well. The presentation of these patients is always absolutely classical, as long as they can remember what they do. And any muscle tendon avulsion always occurs when the muscle is at its maximum length and trying to overcome an irresistible force. So the typical mechanism is the water skiing injury, where someone's getting pulled out of their water skis because the guys hit the throttle on the boat too rapidly, and they get ejected out of there and they feel something tearing their backside, and it's sore. So they have this maximal length and this overwhelming force. So the most common history is the accidental splits, or some similar thing, or we have I'll go through our series later and give you some of the typical things, because being a rugby-dominated country, they get this injury through a specific way, and it's always in the elite rugby players, interestingly. It's not necessarily the elite water skiers, I'd have to say. They get this massive proximal thigh bruising, absolutely characteristic. If you see them late, like 3 months or 6 months, and you say, can you remember the bruise? The person who came with them says, what a bruise. It's a historic event that they remember, no matter how intoxicated they were. They are unable to sit. Inability to sit is another absolutely classical feature. If they have those two features, you almost don't need the MRI scan. And then if you examine them, you can see the bruise if it's early on. And they also get this muscle bunching, which this guy's interesting. He was an All Black, played for our national rugby team. His uncle was an All Black. He was a famous All Black called Smoking Joe Stanley, because he was a chain smoker as well as an elite athlete, which is unusual. And then Joe Stanley's son, Jeremy, is an All Black, and he's also orthopaedic surgeon who's just finished his sports orthopaedic training. So he's a well-connected person, this young man. And he had this injury when he got trapped in a tackle situation and pushed forward by two large individuals over an outstretched leg, and that's a very common mechanism of injury. And the MRI gives you the diagnosis. They often hit, it's a barn door diagnosis, where there's this massive avulsion, a lot of fluid, and this retraction of the tendon. As I say, it can be up to 12 centimetres retracted. So the operative approach, again, you have this flexion position, buttock crease incision, and you elevate the gluteus maximus, place this retractor. Dissection of the sciatic nerve may or may not be necessarily. If we get them fresh within 7 to 10 days, we don't usually make a specific point of looking for the nerve, because it's so easy to identify the stump. But when you get these guys out at 6 to 8 months, you need to find the nerve, and sometimes it's very difficult, and the use of the peripheral nerve stimulator is a very helpful thing to do. Fortunately, I have an anesthesiologist, I think you call him here. His name is Jeremy Cooper. He was an attending at this hospital for 10 years and then went back to New Zealand, and I'm fortunate to have him because he is an incredibly clever individual. So he tells me with the nerve stimulator, he can tell me how close I am to that nerve, and we can find it just using the nerve stimulator and then dissect it out. But you've got to remember that there shouldn't be any muscle relaxant going on, which can cause a problem. So this is this buttock crease incision that we use, and you dissect out the gluteus. It can be surprisingly difficult to find the inferior edge of it sometimes, and then once you've done that, you can elevate it up out of the way. And this is an acute one, and you can put your finger in, you can feel it, and you can flick it into your wound. So it's a very simple thing to do. People get nervous about doing this, and these people get left because some surgeon was getting anxious about the complications, but if you do them within 7 to 10 days, it is a very simple operation. So then the other thing that would annoyed Stu Walsh was that we had 3 failures before 2006 from other people, and they all used bone anchors. So bone anchors went off our menu, and we use an endo tape from the ACL endo button system, or the Merceline tape. In the operating room, we make a tunnel in the ischium, and we often use the old Bankart awls, which they used to use to make the tunnels in the glenoid. It's a very useful device to make our tunnel to pass the Merceline tape through, and that's very hard bone. And once you get the whip suture in the tendon and get it through that bone, you can see here's the tape that we use. That thing isn't going to fail in a hurry. And so then we suture it up onto the ischium, passing it through the bony tunnel, and pull it back to length. And no matter how far out we do these, we never protect them in flexion or anything like that. If you can get it back to the bone, they usually do very well. So we have them in bed overnight. We take the drain out, and the next morning get them going. They get on the exercise bike at 4 weeks because they can't really sit comfortably until then. And and in New Zealand they make these fantastic possum skin, possum hair seat covers, and they're a very useful device for these patients because they make it kind of comfortable for them. And then they start in their strength training at 6 weeks, and at 12 weeks they return to running. So chronic avulsions is much more difficult, and it's a difficult exposure, and you need to be operating on the right patients. So you need to get the MRI to look if they've got fatty infiltration. If their problem is weakness and they have fatty infiltration, you're not going to gain anything by hooking them up again. So the reason to operate on the chronic ones is because of pain, sciatic, neuralgic associated symptoms. If they're weak, they're going to be weak, and you just have to get them a little stronger. And the problem is, especially in someone who's been determined too old for this operation early on, they're in their 60s, and you don't do it, they fall over all the time. It can be a very debilitating thing for somebody. So you can see this is starting to get fatty infiltration, but has retained some muscle bulk, so it's on the cusp of still being salvageable. And again, this is significantly retracted. This lady was a lawyer, in fact, and she had a partial sciatic nerve injury as part of, or palsy as part of her procedure. But fortunately, she'd been told 3 times she shouldn't have the operation, but she insisted on it. And she did very well and got a full recovery. So we've got 23 cases between us since 2006, and 12 of these we operated within 4 weeks. There's a predominance of males, and their average age is 41, but there's 2 groups. There's the young athlete, and there's the older person, late 50s, 60s, who slips on a wet floor or somewhere, gets caught in the splits and pulls it off. So it's kind of a bimodal population. There are 8 water skiing injuries and 6 rugby players who got trapped with their leg extended, and 9 people had slips or falls. We had this one partial palsy in that lady that I showed you. And the other thing we found in our studies, and we've started following these up and doing KINCOM studies on them, is the longer the delay in doing their surgery, the less likely they are to get close to normal strength. And even after surgery, sitting discomfort can still be a problem for these patients, and it's always the skinny ones that struggle. So this is that same guy who was an All Black. He broke the KINCOM actually when he was tested, because he's a strong, angry boy when he gets going, and he was told to do his best. And this is the difference. This is his extension strength, and this is the difference still even after an early repair. So I don't think their strength is ever normal, but it's functional, and he's returned to playing professional rugby. So in terms of these injuries, they have a very characteristic clinical presentation that you should confirm with MRI, because occasionally they aren't separated. Early surgery is technically very simple once you understand that you should flex the patient up to get the gluteus maximus out of the way, and it gives you a more predictable outcome. Thank you.
Basically going to cover prevalence, anatomy, function, clinical scenarios, repair, some results of some of the studies that are published, and then some salvage reconstruction procedures. Just going to highlight through some of these really quickly. But the study by Bunker was with hemiarthroplasties for femoral neck fractures, and they found that 22% of patients that had a femoral neck fracture requiring a hemiarthroplasty had a gluteus medius disruption. The studies for elective total hip arthroplasty in up to a quarter of patients. And then for patients with recalcitrant greater trochanteric pain syndrome, almost half of patients will have these abductor tears. Anatomy's been described for the greater trochanter and its insertions by radiologists looking at MRI and through intraoperative findings. But there's basically 4 facets for the greater trochanter: the superior posterior, the lateral, the anterior, and the posterior. I'm just going to comment that the posterior has no attachments, and part of the lateral and anterior has a natural occurring bald spot. Gluteus medius insertion, the posterior fibers attach to that superior posterior facet, and the central and anterior fibers attach to the lateral facet, while the gluteus minimus insertion attaches to the anterior facet. There's 3 distinct portions to the gluteus medius, and they serve different roles. Posterior stabilizes the hip joint from heel strike to full stance, while the central portion initiates hip abduction, and then the anterior also aids hip abduction but plays a role in pelvic rotation. The exam specific for abductor tears, looking at tenderness at the tip of the trochanter instead of directly lateral, which you'll see with trochanteric pain syndrome. Weakness of hip abduction, Trendelenburg gait, and leg length discrepancy. So MRI, basically posterior you can see the gluteus medius tendon, which should be a homogeneous black area. Same thing with the medius. You can see the boundary, or the minimus. You can see the boundary between the minimus and the medius here, more anterior on your coronal slices. The best imaging series to get are coronal and axial proton density weighted images. These are T1 that shows up, as well as that, and stir images. This is the axial. These are stir images, but you can see posterior where you see the black space for the medius, and anteriorly minimus at a higher axial cut. And then here's a patient of mine that had a medius and minimus tear. You see absence of tendons and some inflammation along that area, and then also this is called a secondary finding for it is fluid signals superior to the posterior superior facet, and you can see it goes all the way down past the trochanter. So it's been described as 3 different clinical scenarios that we'll see it in: chronic non-traumatic tears that are found at the time of open treatment for femoral neck fracture or elective total hip, and then the tears that we see that occur because of a specific approach for total hip arthroplasty. The repairs can be done either open or endoscopic. They're both basically you go in and excise the trochanteric bursa, identify the tear and the edges of the tendon, debride it and mobilize it, decorticate any of the affected facets, and then repair using a non-absorbable suture. You can do that through drill holes or suture anchors. And then depending on how tight the IT band is and whether they have a snapping hip, you may do an iliotibial band release. Briefly covering the results, the bottom is an endoscopic study where they had excellent results with pain relief and strength. Most of the studies are done with non-traumatic tears, and that top one, and these are all referenced in the back of the PowerPoint, but top one, they had symptoms for only 1 to 10 months, and they had some of the best results. The largest study was 89 patients, and about 80% or so had minimal pain or no pain. There's one study looking at a large series of total hip arthroplasties and just observing what they saw around the abductors. Found 8 that they repaired, and those are patients that they found intraoperatively without any suspicion, and they did well. However, going in after a total hip arthroplasty, usually seen with a direct lateral or an anterior lateral approach, The results are not quite as good as what you'd see in the non-traumatic tears. And series are pretty small, 5 and 9. We're able to get by without using walking support. 6 and 9 getting by without using a cane or crutch, and then 5 of 9 without having any type of limp. The reconstructive options, if your repair fails or if you have significant fatty infiltration into the gluteus medius and minimus, Whiteside described a posterior gluteus maximus muscle flap where you take the anterior aspect of the gluteus maximus and place it over the lateral trochanter. There's a crossover flap which combines this gluteus maximus flap underneath a tunnel between the vastus lateralis and underneath the vastus ridge, and then doing the same thing with the tensor fascia. And another study looking at weaving Achilles tendon bone allograft, which has shown some promising results. So in summary, with specific patient population, this can be a common injury. It's diagnosed through history, exam, and MRI findings. Good results with repair in the non-traumatic group and less predictable after total hip arthroplasty.